Hi class, it's Dr. Smiley again. We're wrapping up the lecture component of nitrous oxide sedation, chapters 14 through 19 in your textbook, and going to cover all of these topics. Medicine. So, of course, not only dentistry uses nitrous oxide sedation, but our colleagues in medicine and many fields of medicine use nitrous oxide oxygen sedation. In emergency medicine, in the field, the emergency medical personnel will use a 50-50 mixture of nitrous oxide and oxygen. So different from dentistry. I've got that little photo there on the bottom right just as a I guess a reminder or an awareness that in medicine, of course, with nitrous oxide oxygen sedation, they are using a full face mask. Unlike us, we use a nasal hood because we need access to the mouth. But in medicine, they use a full face mask. And like us, they use it because it has a rapid onset of clinical action. It does not impact the patient's level of consciousness, nor are there significant side effects. Patients benefit from that relative amnesia experience with nitrous. And with nitrous oxide sedation, it doesn't interfere with a physician's evaluation or diagnosis. It's not impacting other body systems. We're going to talk about pediatric nitrous oxide administration, although as a dental hygienist in Michigan, you are not allowed to administer to patients under the age of 18. You do need to be aware of various things with pediatric nitrous administration. And it works just like with adults. It's a safe and effective technique to reduce a child's anxiety and sort of enhance your ability to communicate and to care for them. The single most important factor in the successful administration of nitrous oxide to pediatric patients is the attitude of the practitioner. It's your attitude. If you begin with an attitude of success, generally the visit goes well. So your attitude is the single most important factor. We're talking about nitrous oxide administration today or here, but that's in any care with children. Go into that care thinking you'll be successful, and you generally will be. Pediatric behavior, again, it's greatly enhanced with nitrous oxide sedation, and it doesn't impact other physiologic measures, right? So it's not impacting respiratory rate. It's not impacting pulse. Of course, children would have a smaller tidal volume on average between 3 liters and 5 liters. Just so you know, there are smaller pediatric reservoir bags for nitrous oxide delivery. Children with an ASA-1 and ASA-2 can receive nitrous oxide sedation. Age is not a consideration. There is not a minimal age at which a child can have or not have nitrous oxide. Can a child sit still and breathe through their nose? Those are the considerations for administering nitrous oxide sedation. And also, of course, also, is that child capable of following instructions? Be aware that anatomic features like large tonsils or adenoids can impede gas movement and therefore impact your ability to achieve sedation. Of course, we want to make sure that a child isn't suffering from an active ear infection. Unlike other pediatric medications, pediatric drugs, weight is not a consideration for dose. And if patients, the patients who generally, more often than not, children are patients who are going to be nauseous, let me put it this way. With nitrous oxide sedation, it's the kids. It's not the adults. Kids have more chance of feeling a little nauseous with nitrous. And this is actually related to the duration of nitrous delivery, how long they're on the nitrous, as opposed to how much nitrous was delivered. But nitrous should not be treated as a substitute for just good, traditional, basic behavioral management, right? And so a child, if there is a child that needs nitrous for a specific situation, then it should and can be administered. But it should not be administered just because a parent or a caregiver is requesting it. We can't allow it to become a crutch for that patient, that parent, the dentist. We do get verbal consent from the parent or caregiver. We'll talk about informed consent in a little bit. For specific medical conditions that our children, pediatric patients might have, how do we care for them? A child with sickle cell disease or sickle cell anemia, it's fine to use nitrous oxide sedation. Children with chronic lung conditions, nitrous is okay to use with mild to moderate asthma. It is not for patients with severe or uncontrolled asthma. Mild to moderate chronic bronchitis, okay, but with a physician's consult. Children with epilepsy, nitrous is fine. Children with cerebral palsy, nitrous is fine. Nitrous, we do have good acceptance in children with psychiatric disorders, intellectual challenges, Down syndrome. The use of nitrous oxide sedation in patients on the autism spectrum is somewhat controversial and really needs to be, that decision needs to be made closely with the parent or caregiver. There's a different technique sometimes used in pediatric administration. It's called the rapid induction technique. In this case, 50 to 70% of nitrous oxide is immediately administered to the patient. In other words, the child is not having the dosage titrated up. It is simply started at 50 to 70% and immediately given to the child. Nitrous level then gets reduced after you've achieved your desired effect. Sometimes, in fact, this is called reverse titration. So instead of starting at 0, you're starting at 50 or 70% nitrous. And this is used when you have a significantly uncooperative child and you need to have him or her sedated rapidly. This should only be used by experienced practitioners. Just like with adults, though, signs and symptoms are very similar to adults, right? Eyes should be open, but blinking will be less. The child's going to smile real easily. Their arms or legs may uncross, become sort of limp. They might feel like their fingers or their toes are tingling, sensation in around the lips. So really the same as signs and symptoms for adults. So that's where we're going to wrap up a pediatric sedation. Again, I'm going to encourage you at the end of these chapters in the textbook. There are questions. It's chapter 15. That is nitrous oxide sedation in pediatric dentistry. So make sure you can answer those review questions at the end of the chapter. And now we're going to wrap up things with issues of special consideration. And first things first, potential biohazards for you. So health personnel associated with chronic exposure to nitrous. There's been a history of some controversial literature in nitrous oxide sedation. We'll talk a little bit about that and then find out where we are now. So in the late 60s, a Russian scientist, Weizmann, noted that anesthesiologists in Russia experienced reproductive problems at a significantly higher rate than the general population. So Weizmann concluded that these problems were caused by their chronic occupational exposure to anesthetic gases. One of the anesthetic gases in the operating room was nitrous oxide, and so that was blamed. Of course, there were many different types of gases in that operating room and not just nitrous. Then, 1974, a scientist named Bruce investigated the effects of nitrous oxide on cognition and psychomotor skills exposed to various concentrations of nitrous gas. And Bruce found that there was audiovisual impairment in just hours of exposure with as little as 50 parts per million gas. Since then, multiple attempts have been done to repeat this study, and they have never been able to repeat this study. And the researchers, in fact, retracted their conclusions. But that number, 50 parts per million gas, starts to draw some interest federally. The National Institute for Occupational Safety and Health becomes interested in the studies being published. Then in 1980, a study is published that surveyed more than 50,000 dentists and assistants who were exposed to trace anesthetics. And his results suggested that long-term exposure to anesthetic gases could be associated with an increase in health problems. But in the study, ambient nitrous oxide in the office was never measured. And the data was collected only from dental professionals' memories. So measurement wasn't done, memory was used. And using someone's memory is not science, right? So both this Cohen study and the Weisman study, these studies are retrospective. What a retrospective study is, or means, it means that the study actually begins with a predetermined result. And then scientists work backwards or retrospectively to see what may have caused that result. So in this case, the result they were looking for was health problems exist in healthcare personnel exposed to nitrous oxide. I mentioned the National Institute of Occupational Safety and Health, which recommends no more than 50 parts per million as maximum exposure limit for personnel in the dental setting. But there's no consensus internationally on occupational exposure levels. And again, that 50 parts per million was based on Bruce's, I believe it was Bruce's study that was ultimately found not to be able to be replicated. So the author, one of the authors of our book, Morris Clark, in 1995 does a worldwide literature search, searching biohazards associated with nitrous oxide, and the conclusion, there is no scientific basis for the threshold level in medical or dental settings. So this 50 parts per million, although that has been made standard, there's no scientific basis for it. A maximum nitrous oxide exposure limit in parts per trillion has not been established. I'm going to stop here. When we come back, we'll start talking about some of the specific biologic issues that may be associated or are associated with nitrous oxide use, and continue on.